Hello, I am Dr. GSS Mohapatra, Senior Gynecologist, Laparoscopic and Robotic Surgeon at Apollo Hospitals, Bhubaneswar. Today we are going to discuss and know a few points about one of my most favorite diseases that I like to treat, that is endometriosis. Now, what is endometriosis? What is the incidence? What are the symptoms that patients are going to have? How do we investigate? How do we diagnose the disease? And finally, we will be discussing the management of the disease. Now, the word endometriosis comes from the word endometrium. I mean to say, thus, the inner lining of the uterus, which is deposited at sites outside the expected layer, at ectopic sites. So, when you have it in outside the endometrium, in the myometrium or the outer layer, it is called adenomyosis, which is called the poor cousin of endometriosis. And if it comes out and gets deposited in the tissues which are outside the uterus, we call it endometriosis. Now it can be deposited on the ovaries, on the tubes, it can be deposited on the intestine, it can reach up to the diaphragm. The incidence is huge. Around 170 to 180 million women suffer from endometriosis throughout the whole world. In fact, in India or in the whole world, the incidence tends to be around 1 out of every 10 patients. And out of 30% of every infertile woman that we treat, around 30% will be suffering from endometriosis. Right from Queen Victoria to Marilyn Monroe to the Hollywood actresses to the poor, it doesn't spare anyone. It just spreads like benign cancer. So it just spreads, and that is the reason the patient has a lot of symptoms, because it can spread slowly to various distant sites of the body. Now, the problem with endometriosis is the moment it enters into your body, by the time the manifestations occur, it is around 7 to 9 years. So the patient is facing the symptoms only after 7 to 9 years after the problem has entered into the body. So it is leading to a lot of problems in women going to school, going to office, going to colleges. They have to take holidays. They cannot even get up from bed. It can incapacitate a woman terribly. So, if we discuss what are the symptoms of endometriosis now, the symptoms of endometriosis can range from dysmenorrhea, that is pain, cramping sensation during menses, to dysphagia, which is the pain while passing motion during menses, dysuria, that is difficulty in passing urine during menses, dyspareunia, that is deep dyspareunia. The patient has an intense pain deep within the vagina when she is having intercourse. And finally, it can be we call it the endobelly or dreaded endobelly syndrome. The patient will always tend to have a sense of bloated abdomen, chronic constipation. The patient will always feel that the abdomen is full, and that is how the patient keeps on suffering from dysmenorrhea, dyspareunia, dysphagia, dysuria, and a dreaded endobelly. Now, infertility comes into those patients who are already married and are having endometriosis. Now, how do we diagnose endometriosis? The most basic, easy tool will be to go for a very good high-resolution transvaginal ultrasound. If the ultrasound facilities, since it is a very observer-dependent tool, if MRI facilities are available, then MRI is a fantastic tool for diagnosing endometriosis. And if you find that the symptoms are present, then you classify it and treat accordingly. Now, endometriosis can be classified basically into 4 stages, stage 1, 2, 3 and 4. So as the name indicates, stage 1 will indicate that this disease is more or less started, and 4 is advanced disease. Now, if a ovary shows an ovarian cyst, chocolate cyst, endometrioma, so that is stage 3 of the disease. And by the time it moves on to stage 4, that stage 4 is called frozen pelvis, or it might invade into the deep cervical tissue or the bowel or distant sites, which is called deep infiltrating endometriosis. Now, the patient, whenever we have the symptoms of endometriosis, coming to the treatment cannot be one size fits all. It has to be a customized treatment. It has to be tailor-made based on the age of the patient, the problems of the patient, and the requirements of the patient. Suppose a patient is young, young, unmarried maybe, or just married and does not want conception, she can be easily put on molecules like Dynogest, which is US FDA approved for endometriosis, which I prefer normally much more for patients who have already been treated surgically and then post-operatively. I like to prefer to give molecules like Dynogest. But whenever a patient, whenever a patient wants pregnancy and you need to know what the status inside of the abdomen is, then you need to do a DHL. That is a diagnostic hysterolaparoscopy, and which will diagnose it. This is the gold standard for endometriosis, and you can do a diagnostic lab and do the therapeutic part as well. So if in that case the patient, suppose tubes are cooperative, tubes are fantastic, you can very well do a lapex, that is laparoscopic excision of tissue, and finally send the patient for an IUI, or if the tubes are damaged you can send them for IVF. So if the tubes are fine, post surgery allow them to conceive naturally, you can go in for an IUI. But if the tubes are damaged or they are hematosalpinx, you can send them for IVF. But in a patient who is already completed her family, who has big ovarian cyst maybe, and there is a lot of endometriotic tissue and nodular tissue also which is being found on a transvaginal ultrasound or an MRI which is being picked up by an MRI, then it is better to go for the oophorectomy, that is removal of the ovary. If the uterus has adenomyosis, then removal of the uterus. But hysterectomy and oophorectomy will alone not suffice, which ideally was being told earlier. Why? Because the nodules which contain these endometriotic tissue are self-sufficient in producing estrogen henceforth, and the symptoms of the patient will recur. Hence, the treatment depends on complete excision of whatever macroscopically visible tissue is available on ultrasound, that is laparoscopic excision or robotic excision as we are doing, so that you remove as much as endometriotic tissue as available currently, so that the patient does not have any symptoms in future. As we always say, the first surgery should be the best surgery. It has to be dealt by people who are very well versed, who have a well disciplined team. Like ours, we have a team of a gastro and GI surgeon, we have pain therapists, we have physiotherapists who can address each and every problem of the patient. It is a complete holistic approach, multidisciplinary approach. And in the first surgery, nothing should be left incomplete. It should be a complete surgery so that the patient doesn't have any recurrence in future. So, to sum it up, it is a dreaded disease. The incidence is detected more and more nowadays because patients are coming up with the complaints and detected by better high resolution ultrasounds and MRI. The treatment, coming to the medical treatment part, the treatment is always it depends on whether what the patient requires, whether the patient is young, patient is old, whether we are prescribing a medical management post-surgery or pre-surgery. Then the surgery depends on what, suppose it is a fertility enhancing surgery, patient is young, you need to do a fertility enhancing surgery. That is, you have to be radical towards the disease, conservative towards the function. If the patient has completed her family, then you have to do a hysterectomy, bilateral salpingo-oophorectomy, as well as removes excision of all nodular tissues. It might even have to go a resection of segments of the tissue in the bowel, which might be a discoid resection. It might be just shaving, or it might require removing one segment of the whole intestine, which is called a segmental resection bowel, and then bowel reanastomosis. So if one size doesn't fit all, it has to be tailor-made based on the requirement, the age of the patient. Thank you.